Welcome to the MS-Perspektive podcast, Perspective with a K as I'm German. I'm Nele von Horsten, MS patient, patient advocate and author. I'm bringing you interviews, inspiration and information about living with multiple sclerosis and show you ways how you can positively influence the disease and make the best out of your diagnosis. On ms-perspektive.com you will find the show notes, 11 free tips as a PDF and lots of other information. And now the show begins. Thanks for tuning in again and welcome to episode number 87, Understanding and Managing Neuromyelitis Optica, NMOSD, Latest Advances in Treatment with Professor Dr. Luis Alfonso Zarco. Hello Luis, it's such a pleasure to have you on the show. Hello to Colombia.
Hi, it's a big pleasure for me to stay with you talking about demyelinating disease. Thank you so much for inviting me, Nele. I am ready to participate in your podcast.
Fantastic. And before we actually start with the podcast about NMOSD, it would be lovely if you could introduce yourself to the audience so they know who is with me on the show today.
Okay, I am Luis Alfonso Zarco. I was born in Barranquilla, the fourth biggest city of Colombia, near to the Caribbean coast. I studied medicine at the Universidad del Norte at Barranquilla. I am a neurologist from Pontificia Universidad Javeriana at Bogotá, and I'm neuroimmunologist from Universidad Autónoma de Barcelona. And I candidate to master in demyelinating disease, multiple sclerosis, from Dresden International University and fellow of the European Charcot Foundation. I work actually in Bogotá, the capital city of Colombia. I work at Universidad Javeriana at Hospital Universitario San Ignacio. I am professor of neurology for undergraduate students of medicine and for the training of residents of neurology at Pontificia Universidad Javeriana. Actually, I am the director of the neuroscience department of Universidad Javeriana and Hospital Universitario San Ignacio. Hospital Universitario San Ignacio take care about 40% of the high complex disease at the Bogotá. And I am married with Angelica Rico. Angelica is a nurse. She works in occupational health. And we have a daughter, Maria Paula. She is a lawyer. And Luis Carlos, he is studying finance in Bogotá. And I love my profession. I love take care of patients with demyelinating disease. For me, it's important because people with demyelinating disease has disability. That disability affect the quality of life of the people, interfere with the desires, with the dreams, and the people need to achieve their goals, and we can help them to get their goals, and it's important for us this aspect.
Absolutely. And congratulations to your lovely family. It's always good to have such a great family. What was your personal motivation for your career choice, Luis?
Okay, my personal motivation is the possibility to help people with disability. In the neurological area, people is affected in the relationship with their families, with their society, with the works, and take difficulty to get to achieve their goals, their dreams. And as neurology, we take the possibility to help their people with treatments, with psychological support, with the rehabilitation, and it's a big opportunity to help the people, to help the society, and this is the main motivation for me.
Absolutely, yes, I can understand that. So before we actually dive deep into NMOSD, could you please explain what Neuromyelitis Optica Spectrum Disorder, so for short NMOSD, are, and how does it differ from multiple sclerosis?
Okay, NMOSD is a autoimmune disease, is a demyelinating disease that is produced by autoantibody, specifically autoantibody whose target is aquaporin 4. Aquaporin 4 is a channel protein that is present in the central nervous system, specifically in the foot of astrocytes that are present in the central area of a spinal cord, at the optic nerve, and the brain stem, especially in the area postrema, and the encephalon and the cerebellum. And the disease is an inflammatory disease that the clinical course is by attacks and relaxes. The attacks can produce disability, residual deficit with each attack, and the attacks are recurring on the course of the disease. Probably the NMOSD affect some similar anatomical sites in the central nervous system to multiple sclerosis, for example, spinal cord and optic nerve. But the inflammatory mechanisms that play a role and the magnitude of inflammatory process is so different. And the clinical expression of the inflammatory process is different. For example, patients with multiple sclerosis can have optic neuritis, but the loss of vision is mild, and the patient can recover in a spontaneously form. But in the case of neuromyelitis, the loss is important. Often the patient lost the visual acuity over 20 over 200. It's a very important loss of vision. And the patient need the treatment of steroids plus plasma exchange for get the recovery. The same situation, the same situation is in the spinal cord. Probably a patient with multiple sclerosis have very mild sensitive symptoms. For example, mild loss of mobility of strength of the extremity, and it's different in the NMOSD, in which the patient lost all sensations. The patient can have paraplegia and quadriplegia. In some cases, it's a very severe attack. So, in summary, the magnitude of the severity of the symptom is different. Is so severe in the case of NMOSD. And another important aspect is the disability. Patients with NMOSD have the disability in association with the attacks. The attacks are the main drivers of the disability. But in multiple sclerosis, the patients have a PIRA, progression of the disability independent of the relapse. There are some differences in the two diseases.
Yes, thank you. And what are the typical symptoms and onset patterns of NMOSD, and how do they manifest over time?
Okay, there are a specific phenotype The most frequently is longitudinal extensive myelitis is the first. The second, optic neuritis. The optic neuritis can be unilateral or bilateral. The third expression is the combination of optic neuritis plus longitudinal transverse myelitis. And in some patients, we can observe area postrema syndrome with hippicles, nausea, and vomiting. And a minority of patients can be expressed narcolepsy, for example, for the encephalon impairment. In summary, myelitis, transverse myelitis, and optic neuritis are the main symptoms of the disease. And these symptoms can recur, the patient can course with relaxing attacks with these symptoms.
Okay, thank you. How important is early diagnosis in managing NMOSD, and what are the key signs that lead to diagnosis?
Okay, the early diagnosis is so important to prevent the disability. Only 25% of the disability progression of the disability in patients with NMOSD is associated with the first attack of the disease. And if you perform an early diagnosis and put a high efficacy treatment, probably we can prevent new attacks of the disease and we can prevent the progression of the disability. And it's so important early diagnosis. And it's important an early diagnosis too, because if you delay the treatment of relapse, the patients lose the possibility of a good recovery. For example, if a patient delay the access to the treatment of the relapse, lose a 30% of possibility of get a full recovery. And in a patient's delay 1 month to access to the treatment of the relapse, lost a 70% of possibility to get a full recovery. In summary, it's very important. A very early diagnosis of the disease, a very early diagnosis of the relapse for put the patient on treatment very early, very fast.
Mm-hmm. How does NMOSD typically progress over time if left untreated or inadequately treated? I guess there are some knowledge from the past, because I guess in the past it was not always an early diagnosis and early treatment.
Okay, patients we don't have treatment have a high possibility of relapses. For example, a patient that don't have treatment have a 52% of a relapse in the next 2 years. That is very important. I repeat, the main drivers of the disability in NMOSD are the relapses. It's important to prevent the relapses, and it's important that all the patients with diagnosis should be treated.
So how much does the prognosis depend on the type of treatment?
The treatment is so important for the prognosis. For example, now we have very high efficacy treatment. Traditionally, we use in the past the first line immunosuppressants. Immunosuppressant can work, and the disease prevent the disease, but have a variety of adverse events and help to prevent the attacks. But the better performance between efficacy and safety is with monoclonal antibodies. For example, a patient with monoclonal antibodies have a high possibility to reduce the relapse rate. There are some monoclonals that reduce uh, about 70-80% the possibility of a new relapse. And some antibodies, monoclonal antibodies, has a possibility to reduce in the 90%, includes the possibility a new relapse. And the natural history of the disease is different if the patient have treatment. It's different now with the novel antibodies, monoclonal antibodies that we have and can use to reduce the possibility of attack in a very important mode.
Great. Okay. Is there a particular group of patients that tends to experience more severe outcomes from NMOSD?
Yes, there are differences in demographic factors. For example, patients with Afro-descent race has a more possibility of attacks. These patients has have a high risk of blindness, for example. For example, in the Japanese patients, the possibility of relapse is lower. The possibility of disability is lower compared to white people, for example. The young patients has uh, more risk of relapses and optic nerve recurrence attacks, different with old patients that have a more possibility of motor motility. And female has high risk of relaxes compared with male, for example.
Okay, interesting. And how important is symptomatic treatment in NMOSD patients, and are there special forms that are leading?
Okay, it's very important because the patients have pain, spasticity, neurogenic bladder, for example, and we can uh, help patients with symptomatic treatment, for example, Botox or botulinum toxin, for example, for spasticity, baclofen for spasticity, neuromodulators for control the pain, and different treatments for the hyperactive bladder. That is important. In men, for example, erectile dysfunction is an important thing, and we can help with different medications. Another important point is the fatigue. Similar to multiple sclerosis, patient with NMOSD has fatigue, and we can help with exercise, resistance exercise, cardiovascular exercise, um, different techniques, neurocognitive behavioral treatment to help people with fatigue.
Great. You already talked a little bit about it. What are the standard first-line treatments for NMOSD, and what is their mechanism of action?
Okay, from my personal point of view, and take into account the evidence of the last studies, now in this time, I think the first line from my point of view are monoclonal antibodies. Why? Because we can get better outcomes. For example, reduce the relapse rate in a very high important mode. We have, for example, satralizumab is a monoclonal antibody who works targeted with a receptor of interleukin 6, for example. Eculizumab, that is a monoclonal antibody targeted with C5 component of the complement. Inebilizumab, for example, anti-CD19. And in some countries, we use off-label rituximab, an anti-CD20 agent, a monoclonal antibody too. This monoclonal antibody reduces in a significant proportion the risk of relapse rate between the 70% to 90%, and is so important. But in some countries, people don't have monoclonal antibodies. In this case, can use the traditional first-line therapy, for example, immunosuppressant, the combination with azathioprine plus prednisone or mycophenolate. But in this time, probably we have access to monoclonal antibodies. In the countries that we have monoclonal antibodies, the first line, I think, should be the monoclonal antibodies. But if you don't have monoclonal antibodies, but you have to take into account the immunosuppressants. The immunosuppressants have lower efficacy compared with the monoclonal antibodies and have some adverse events. But if you don't have any chance to use monoclonal antibody, you should use the immunosuppressants.
Yeah, better do something instead of not doing anything. What are the main challenges in making monoclonal antibody treatments more accessible for NMOSD patients worldwide?
Okay, I think it's important to combine the leader of the health system in the different countries. It's important to invite the different stakeholders, pharmaceutical industry, for example, scientific societies, patient associations, with the leaders of the different health system of different countries, and put in the table of conversation the importance of the access to the monoclonal antibodies, because you found in this type of medication a high possibility to control the disease, a high efficacy, and a good relationship between the efficacy and the cost. The cost effectiveness is high, and it's important to work in the idea of facilitate the access to the patients to this medication. Is very important. If we have monoclonal antibodies for the patient, we reduce the possibility to the patient disability.
Yes, absolutely. How important is continued research into personalized treatment plans for NMOSD patients based on genetic, clinical, or biomarker differences?
It's fundamentally because not all patients have the same response to different treatments. For example, in Colombia, in some cases, we use rituximab in a off-label mode. And for example, there are some patients that have polymorphisms of FC portion of the natural killer cells, and the rituximab in this patient don't work in the same mode and don't deplete the B cells in an important mode. And this patient don't have a good response because the mechanism of action imply the cytotoxicity mediated by antibody. And in this patient with this genetical background, the rituximab downwards. Is an example. Some patients with rituximab therapy have a very fast repopulation of CD19, CD20 cells, and we need to monitor the response with flow cytometry for CD19 and CD20, and we can see some patients have a fast repopulation, and we need to put this patient in a short interval between the different infusions. It's an example of two situations that we observe. And we need to personalize, to individualize the treatment depends of different variables, the genetic background of the patients, the comorbidity of the patients. For example, satralizumab can produce elevation of lipids, for example, and can produce overweight, increase the body weight in some patients, and you need to choose the treatment according to the comorbidity, to the occupational of the patient, of different variables, and we need some biomarkers for this purpose.
Okay. Very interesting. We are coming to the quickfire Q&A session, Luis. Complete the sentence. For me, NMOSD is?
It's a big opportunity to help patients, families, people that they can continue with their goals, with the dreams that people have. It's the opportunity to help the people to produce to the society. And it's a very important mode to help the people. It's a big opportunity for us.
Yes. What development would you like to see in the field of NMOSD in the next 5 years?
Okay, there are some groups in the world that are looking for new developments. For example, the CAR T cells. I know that some groups work on chimeric antigen cell, CAR T cells, and other groups are working in increase the tolerogenic response, immunological response. Some groups are working in dendritic tolerogenic cells that can increase, for example, interleukin 10, that is an anti-inflammatory interleukin. We hope some new developments in the future. CAR T cells and tolerogenic dendritic cells.
Okay, finally, what message of hope or encouragement would you like to share with individuals living with NMOSD?
Okay, I say you are not alone in the world and living with the disease. There are many clinicians, researchers, social workers, psychologists, patient associations, scientific societies, and other stakeholders, for example, pharmaceutical industries, that work all the time around the globe to find new developments, new treatments, and looking for a better quality of life of the patient with NMOSD. And be patient, don't worry, and you are not alone on the world.
Thank you. I think that's an important statement. Luis, how and where can interested people follow your research activities?
Okay, at Instagram, my Instagram, let me see a second. My Instagram is at underline Zarco, Dr. Zarco. Excuse me, is dr at line under Zarco.
Okay, and of course I will link it in the show notes and in the blog article. Luis, thank you very much for sharing all these insights into NMOSD. Thank you very much for your research and of course for taking care of patients. And greetings to lovely Colombia, and I hope to see you at one of the next spectrums, maybe.
Yes, probably. I'm going to see you on the next in the next entrance. It's a pleasure for me to talk with you in your podcast. Thank you so much for inviting me. Excellent night in Germany now. It's important for me this space. Thank you so much, Neil.
Thank you. Bye-bye.
Bye-bye, Nelly.
I hope you enjoyed the interview and learned something new about NMOSD and how important early treatment is. By the way, next time I will be talking to Dr. Andreas Luterotti about immune tolerance and MS, how the RED4MS study could change MS treatment. Very interesting interview, so you should tune in again. And remember, stay as healthy and positive as possible and rate the podcast wherever you are listening to it, recommend it to other people. And of course, if you have certain requests for topics, please let me know and I will try to bring dedicated people to the show who could answer your questions. So thanks and see you next time. Bye. Thank you for listening today. I hope you found it helpful. You may also be interested in the previously published episodes and posts, which you can find at ms-perspektive.com/podcast. Perspective with a K. You can also get a free PDF with 11 tips for your positive impact on MS at ms-perspektive.com/newsletter. If you'd like to get in touch, you can reach me at nele@ms-perspektive.com or on social media. See you next time.